Ethical Perspectives on the News is produced by the Interreligious Council of Linn County, which is solely responsible for its content. The views and opinions expressed on this program do not necessarily reflect those of the staff and management of KCRG TV9.
Good day and welcome to Ethical Perspectives on the News. My name is Linn Tabak. I'll be our moderator for today's discussion. Our topic is precision medicine. This is sometimes called personalized medicine. And I was moved to propose this topic to our producers when I watched a video on YouTube called A Computer Scientist's Trying to Save His Son. I teach computer science myself. This particular professor named Matt Might, you can find this easily on YouTube, had a son with his wife who was seriously ill. And using his knowledge of computer science, he was able to help identify a defective gene, find some medicines that were effective in treatment, and also find other families that were afflicted with this rare illness. So it was a combination of computer science, genetic technologies, medicine, that was able to deliver a very specialized treatment to help somebody who was very sick. We're going to learn more about this with the help of three guests, and all from the University of Iowa, all professors at the University of Iowa. Dr. Benjamin Darbro is a professor of, or associate professor of pediatrics, and will tell us a little bit more about his involvement in this field. He is the first person I found. I found his name in print as I searched for people who are writing about this subject. And then he recommended to me his two colleagues. Professor Sandra Daack-Hirsch is in the College of Nursing and apparently has some involvement in genetic counseling that I hope we'll hear about. And Professor Anya is at the College of Law and also interested in genetic issues of some kind. They've got a group over there in which she'll tell us about in a moment. So let me ask you each to say a little bit more about your backgrounds, what brings you to this subject, your involvement in the subject. Introduce yourself a little bit more to our audience. Do you want to begin, Anya?
Sure. Thank you so much for having me. I'm really excited for this discussion. So I am a professor at the College of Law, and I do research in the ethical, legal, and social implications of genetic and genomic technologies. And so that's shortened to ELSI, the ethical, legal, social implications. So I'm an ELSI researcher, and most of my research focuses on genetic discrimination and genetic privacy. But I look forward to the conversation. Thanks.
Oh, very good. And Sandra, do you want to say something about your role?
Sure. Hello, and I'm pleased to be here tonight. My clinical background is in clinical genetics, caring for children and families that have inherited disorders or children who are born with birth defects. And I did that for about 17 years before I went back and got a PhD. My area of research has to do with how families communicate risk with one another, especially when they have an inherited mutation that causes a disorder or disease that has a pre-symptomatic phase. My other area of research has been how the public responds to whole genome testing, so scanning the whole genome, and then dealing with what we would call secondary findings, so findings that are not necessarily associated with the reason that the person was tested.
Oh,
so I also look forward to the conversation. So.
All right. And Dr. Darbro, Ben, what is your involvement with precision medicine or personalized medicine?
Well, so even though I am in the Department of Pediatrics, I generally tell people that I'm the last pediatrician you'd ever want to see, since I'm actually a pathologist. So all of my clinical training is in pathology and in clinical and molecular genetic pathology. So in addition to my training, I've also, my PhD was in molecular and cellular biology, and my current position is as the director of our Shivanand Patil Cytogenetics and Molecular Laboratory at the University of Iowa Hospitals and Clinics, and also as the associate director of the Iowa Institute of Human Genetics. So in addition to my clinical role, which is largely actually the one who does the testing, this genomic and genetic testing on patients interprets those results and sort of how they're going to impact patient management. I also do research. A lot of my research is involved in specifically trying to elucidate really what's going on sometimes at this genetic level, specifically with something that I'm sure we'll probably discuss tonight, which is variants of unclear clinical significance, as well as research within several different types of cancers, looking for genetic and genomic biomarkers for things like prognosis and therapeutics. And let me tell you, I'm the low guy on the totem pole here. We've got some excellent other experts here tonight, so I'm really looking forward to this discussion.
Okay. Now, I think from my reading, it looks like there was a major push to make progress on this area of precision medicine some years ago, sponsored by our federal government. Is that the case? Is this a new field? Is it a field with lots of backing from the government? What do we know about that? Maybe not.
I could say really quickly that so precision medicine as kind of as just a term is still relatively new. You had mentioned early on sort of this idea of personalized medicine, precision medicine. They're really not the same thing. Personalized medicine has been around for centuries. Actually, Hippocrates practiced personalized medicine. Every patient he saw, he would assess their 4 humors, bile, phlegm, and so forth, and give them a very personalized treatment program. Personalized, but not very precise. And you'll notice that the term precision medicine itself has only been around, I think, since about 2012.
Yeah.
But there has been a tremendous investment in precision medicine. And in fact, I think a lot of it could probably be sort of summarized in the fact that the NIH has started this thing called the All of Us program. And it really is a research project that is multifaceted. But the short of it is that they're recruiting 1 million individuals. And they're going to do a lot with these individuals. In addition to just looking at their genetics, they're also going to be asking them questions about, like, the environment they live in, other phenotypic characteristics, things like that, to try to get a much better picture of how genetics and environment really do interact with one another, and how that actually then can cross-section with medicine, and whether or not that can be helpful in, making decisions for medical management. So in addition to that, there's also multiple RFAs that exist for precision medicine through the NIH, through multiple different institutes. So I would say that, yes, there's been quite the investment.
Yeah. I would add to that I think that precision medicine is just an evolution of clinical genetics, and we've moved from genetics thinking of it as kind of a single gene disorder inherited. I mean, these things are inherited, but that they would only affect a minority of people or a minority of families, right? And not everyone. And the genome, the Human Genome Project was really to, put genetic tools into the hands of many types of providers, saying that, this our genetic underpinnings don't, and things that go wrong there don't just affect a small number of people. Really, it has an implication for just about every kind of disease or response to different treatments. And so we're looking at not just a single gene and how that creates a single disorder, but how these things all work together. So that evolution, I think, moves it out of this. It's a specialty where you would go to a specialized clinic to, looking at the complement of genes and other health factors that affect people's wellness, a spectrum from being well to being sick.
Okay. Maybe you can tell us, Anya, about how much genetic information we have and the variety of ways in which people are using information about their genes.
Yeah, so as you can hear from some of the answers, I think another piece of this is that the reason why we can have precision medicine now is that we have all these technologies that can pool together data from millions of individuals and really run algorithms to figure out what's associated with what. But what this means from my perspective, I see millions of individuals of data, right? And so one of the things that's interesting is thinking about who should own that data, who should have access to that data. A lot of this is done through what's called de-identified data. So you have your genetic information sometimes that it would say, this is Anya Prince's genetic information, but then you could strip details from it and it becomes de-identified. It just becomes some data out there. And so there's lots of discussion about, what does that mean to have my data or your data, right, in a biobank that research is being done on it, but you don't necessarily know whose it is, right? The researchers don't know the names of the people behind that. So lots of interesting issues about just the millions of people who help us to do this research.
Okay, I'm the newcomer here, so I'm going to speculate a little bit, and you stop me if I'm going down the wrong road. I think I have read that in the past, if a chemist discovered or synthesized a new compound and thought it might be useful as a medicine, we'd test it on 1,000 people. And if it had a good effect for 900 and it did nothing for 50 and it hurt the other 50 only a little bit, we would say that's a good medicine, we would authorize that. And we are reaching a point where we could test that medicine and see that it only does good for 20 people. But we could identify what the special characteristics of those 20 are. And we could then have a greater variety of medicines. A medicine that works for me might not work for you. Am I on the right track there? Is that a part of our subject here?
I would say yes. And not just the right medicine, but even the right dose of the medication,
Okay.
or maybe that it's a family of medications that might be good for you, or a combination of things that might be better for you than it might be for someone else. And it's to, reduce the side effects that medications have as well. So, the hard part about taking a lot of medications is the other things that the medication does that makes you feel kind of crummy. And so, you want to be able to tailor the medications and the dosage to the body's chemistry so that you're getting the best effect without having extra problems.
Okay.
Yeah, we talk about, that's a very common sort of buzz phrase, the right medication for the right person at the right time, sort of all falls under that umbrella of very commonly referred to as pharmacogenetics or pharmacogenomics. And I do think that is a very good example of precision medicine. So basically that idea of identifying a subgroup of individuals that would greatly benefit from a particular medication, very much in the vein of what you described. Pharmacogenetics, I always find, though, also has kind of a unique aspect, which I think does intersect a little bit with some of the ethical, legal, and social implications as well. And that is that, whenever we do a very big genetic test, like if we're testing a patient and we're looking at, say, all 20,000 of their genes, we might be doing that so that we can better diagnose, say, a congenital disorder. But in addition to that diagnosis, we might have all the rest of this data that could still prove useful, hypothetically. At least one of those things could be pharmacogenetics. And, that's also when some of these issues of, what data do we, should we have access to? What data does the patient give us permission to actually look at? Because some of that information could potentially be very beneficial and we would have that. But that brings into that question of, whether or not that's information that, should just be automatically used, or what are the levels of consent that need to be, informed consent that need to be provided and then accepted.
Well, what could I expect to hear from somebody who's providing me with care? I made a comment to you in my correspondence that in my own recent experience, care providers have tried to, in making a pitch that I should do this or that to care for myself, they've given me outcomes of other patients with general statistics. They're comparing me to maybe to other men my age, but it's not very specific. And perhaps in the future, it will be much more specific about my ethnic origin or other details of my life that, yeah. So that opens lots of questions
Yeah,
for
it
me.
does. Yeah,
And
it
then
does.
in telling me that I might be more vulnerable to an illness, they might also be predicting future illness, and I might not want to know that. If there's the ability to look closely at my particular characteristics and tell me, you know, the clock's running out for you, Leon, I might not want to hear that news.
Well, you know, I think Sandy could probably talk about this quite a bit too with the secondary, you know, variants
Yeah.
and so forth.
Yeah.
But you know, that is something that, you know, that is a big component of precision medicine. And I would say just in genetics and genomics in general, kind of always has been this idea of other information.
For sure.
You know, I think some people forget that in genetics, when we're talking about healthcare, you know, the patient who's in front of you is not really the patient. It's really their entire family that you're doing testing on whenever you're doing a genetic test. And yeah, so I think that, you know, some of these things that, you know, you may or may not want to know, these secondary variants, as we generally, it used to be called incidental variants, but secondary variants, these are things that, you know, nowadays are always mentioned up front. Whenever you're having one of these tests done, what are some of the possible things that we could derive from this test? And then, of course, after being educated about this, the patient is asked, is this information that you would want to know? And we do try to make it, you know, a little bit easy in that we generally only will offer the information that we can do something about. So the example that I'm sure many people have heard about is like BRCA or BRCA and inherited breast and ovarian cancer. And I think that my face looks a little frozen there. Is it frozen to anybody else?
Yeah.
We lost the video on you
we
here. We
did.
still hear your voice. We still
Okay,
hear your voice
fantastic,
clearly.
fantastic. But anyway,
Yeah.
BRCA and I think Angelina Jolie was probably one of the early faces of that just several years ago.
Okay.
And the thing about that is that, you know, if we find one of those variations or one of those mutations, there's something that can be done. You know, there's preventative measures that can be taken, but there are some situations where that's not the case. Like if we were to find that somebody had an increased risk of Alzheimer's disease, there's not really a preventative treatment or something like that that can be offered in those situations.
Mm-hmm.
So there's kind of a difference between information that we provide and what we don't provide, or even, you know, give the patient the option to get that information.
So just to add to that a little bit, and you know, we call genetic testing as if it's just one thing, and genetic tests are designed to do. Sometimes the genetic test is very specific. It's looking for a mutation because a patient has a set of symptoms that are characteristic of a disorder that we're pretty familiar with, or they have a very strong family history of something that we know, like myotonic dystrophy or Huntington's disease. And so you would do a test that really tests for that disease and nothing else. Other times a genetic test is a panel of genes or a panel of sequences that are, we know to be sort of areas of risk in the genome that might say that you're at risk for diabetes, for example. And then other times patients, the genetic test is really whole genome or whole exome screening. So, you know, all of the entire sequence of the genome, or a sequence that's just related to the kind of coding areas of the gene. And every time you add information or more of the genome into the genetic test, you run the chance or the risk that you'll discover something else in addition to what it is that the patient is being tested for. And so that opens up a can of ethical and legal implications that I'm sure Anya will pick up the conversation on. But if it's a test and it's a clinical setting, the idea is that you will give patients choices to, you know, opt out of not learning about those other variants if they don't want to.
All right. Well, Anya, I want to hear about the ethical concerns that are of greatest interest to you and your colleagues at the law school.
Yeah, I mean, I think some of these that are starting to come out from this conversation is what type of results somebody gets, and there can be several implications for this. One is, how do you communicate to family members? If there's one family member that wants to have this information and another family that doesn't, is there a right not to know your genetic information? That's a big ethical discussion. Another that comes out of this is a fear about genetic discrimination. So this is, are there entities in the world that might also discover this information and then use it in a way that people wouldn't want? And the big example is, for example, life insurance companies. In every state in the country except for Florida, life insurers can charge different rates depending on your genetic information. And so if you are doing a test for one specific disease and then find out that you actually have a family history of, for example, the BRCA that increases your risk of breast cancer, is it fair for insurers then to charge higher rates based on that risk? So some of that implicates how we have other privacy protections, whether you're doing a research study or in clinical care, how that information might get to an insurer. But there's lots of issues about who has access to the information and what they're allowed to do with that information beyond just its beneficial use in healthcare itself.
Okay. So again, I'm a newcomer to this field, but I think that part of the driver in this field is that it's become much less expensive, much more practical to look at our genes, to map genes, so that technology has improved rapidly. And then, as I said, I teach computer science. There's been rapid progress in learning how to use large amounts of data and extract information of value from it. Are there other principal technologies that are driving this move towards precision medicine? Are we overlooking anything?
I don't know about technologies. Maybe Ben can talk more
Okay.
about technologies, but it's definitely things like 23andMe and ancestry testing and things like that. It's become more accessible, genetic testing or genetic screening, and so it's not such a foreign concept for people to think about their genes and their genetic makeup. I mean, people use DNA and genetics to sell products and makeup and food and all kinds of things. So I think that it's not so mystifying for people, and so their acceptance of genetic testing and what it can do for you is also part of the drive in addition to the technology.
I'd love to say something about the cost piece, because you did mention how the cost of testing is going down, and I think that's one reason why we're having more of this. But I think it's really important to also think about the cost of care. And so if we think back to your example, Leon, of finding a drug that works for the 20 people rather than the 80 people, one thing is that from a drug manufacturer perspective, you have fewer customers, right? And so you actually have to make the drug more expensive the rarer the population is. And some of this research can be expensive, even though the genetic testing is not. And so one big ethical concern in precision medicine is that we can create some really amazing treatments, but some types of therapies that we have coming out now are millions of dollars, right? And maybe they can cure a genetic condition, and so maybe that's worth it, but only certain people are going to be able to have access to that. And it will really strain our systems, our insurance systems, our health insurance systems, if a lot of people need this type of care. So cost is a really big issue for access and just for feasibility of continuing this care in the future.
Okay. I came here to Iowa from Massachusetts and lived very close, the next town over, from Framingham. Framingham is famous for a very long study over many years related to heart disease. So that prompts me to ask, is somebody going to be soliciting my genetic information? We have to correlate these different patterns to identify where disease originates. Are there large projects underway already that I don't know about? Are there incentives for people to participate? How are we gathering the information that will inform future medical decisions?
Ben alluded to the All of Us project, so maybe you want to talk a little bit more about that, but that's the big initiative right here in the States to get phenotypic and genetic information from many, many people so that it can be, uh, cataloged and stored and then used indefinitely, to be able to, learn more about, rare findings as well as common findings, but and to learn more about lifestyle and other factors that would influence the expression of genes. And, that's the largest one that I can think of in the States.
Yeah, I mean, and there are at any large academic institution multiple other studies that are going on that might be recruiting based upon a specific condition, phenotype, or demographic as well. And there's no shortage of those, as well as clinical trials. Maybe more so in things like cancer or other actual disease states. Also recruiting individuals. A lot of that data that gets acquired in those kinds of studies, usually as part of the consent documentation to enter that study, that the question is asked, would you be okay with using your de-identified data in other research projects? So there's a lot of data that's generated in that way as well that's going towards this pursuit of really furthering precision medicine by getting a better sense of what the what the normal is. I hate using the word normal. Nobody's really normal. We're all mutants in some way. But to get an idea as to what the general population looks like with regards to genetic variation, which is a much harder task than it sounds like. And a lot of that has to do with, who are the people who are in these studies and who are the people who are volunteering to provide their samples. Who are the people who are contributing data to things like 23andMe or Ancestry.com. All of those things kind of skew what our population databases kind of look like. So we still have work to do to make sure that those are a little bit more inclusive of all the different types of individuals and ancestries that we have on the planet.
Okay. We've got about 30 seconds for each of you to say a parting word. Anya, do you have something to say here as we wrap up?
Sure. Yeah. Thanks so much for the conversation. And I'd just say if people are interested in learning more about the ethical, legal, and social implications of genetics or genomics, the NIH, the National Institutes of Health, has funded a group called LC Hub. It's a national organization that has a lot of resources about LC topics. So you could check that out to hear more about LC issues.
Okay. And Sandra?
Yeah, again, thank you for having me. It's a great 30 minutes. I guess I would make a plug for healthcare providers, all types of healthcare providers, to really embrace genetics and genomics. I think that's another barrier to patients being able to have access to this, is not knowing how these things work. So I think that would be my plug.
And Ben, we have time for you as well. A last word.
Yeah, man. If only we had more time. I'm sure there is so much more we could discuss. But I guess what I would say is just to echo the statements that have already been made, and that specifically with regards to like the All of Us, pretty easy to Google that. You can find that information, or to go to the Iowa Institute of Human Genetics website, which is part of the University of Iowa's larger College of Medicine website. You can find a lot of information there, just educational information that would be appropriate for both patients as well as providers.
Okay, very good. Well, thank you all for joining our conversation today. We had 3 great guests, and I hope our audience now knows more and is more interested in this very important topic. Thank you at home for joining us, and we hope to see you on our next show on Ethical Perspectives on the News. So thanks, Sandra, Ben, and Anya. Great to meet you all. And interesting to know that we have this kind of work going on here in near home here in Iowa.
Yeah.
Okay. Good day. Bye-bye.
Bye. Thanks.